Hey everyone, and welcome. I am absolutely thrilled to have you here today. Go ahead and consider me your senior clinical instructor for this explainer, which is basically going to serve as your comprehensive orientation to your gerontology and home care rotation. We are officially stepping out of the highly controlled traditional hospital ward and heading straight into the community, where honestly, the rules of assessment and care change pretty dramatically. Our goal today is simple but absolutely crucial. We're going to equip you with the knowledge to look at an older patient and truly understand what's happening to them biologically, psychologically, and socially. So, here is our game plan for today. We'll be covering 1. Confronting ageism in care. 2. The science of aging. 3. Normal aging versus chronic illness. 4. The changing body and mind. And finally, 5. Delivering holistic geriatric care.
Okay, let's jump right into Section 1, Confronting Ageism in Care. Because before we even think about touching a stethoscope, we really have to lay down the ethical foundation of our practice.
Ageism is defined as a bias against older people based solely on their chronological age, totally ignoring their actual functional status. As home health nurses, you've got to wrap your heads around the fact that the number of years someone has been on this earth does not automatically dictate their ability to walk, think, or live independently. Chronological age, it's literally just a number. Functional status, what they can actually do, is the reality you'll be nursing. Dependent, frail or weak, poor, lonely, unable to learn, difficult. Now be honest with yourselves. How many times have you subconsciously attached these exact labels to an elderly patient before you even took their vitals? I'm challenging you, right here, right now, to check those biases at the door. Treating a patient like a walking stereotype completely blinds you to their unique, individual needs. And here's why dismantling these stereotypes isn't just a nice idea, it's an urgent clinical necessity. By the year 2030, older adults are going to make up 20% of the population. That means 1 in 5 of the patients you see will fall into this demographic. If we drag ageist assumptions into our daily practice, we are actively failing a massive, growing segment of our own community.
Moving on to Section 2, the science of aging. Let's look at the structural foundations of geriatric nursing. These are the medical and sociological theories that actually explain the why behind what's happening to our patients.
First up, we need to talk about senescence. Big word, I know, but it simply refers to a change in the behavior of an organism with age, which leads to a decreased power of survival and adjustment. But here is the really important part. Aging is not just a sudden endpoint, and it definitely isn't a disease. It's a total, lifelong process that literally begins the moment we're conceived. Senescence is just the phase later in life where our physiological reserves start to wane.
Let's break down these complex aging theories into some bite-sized, memorable concepts. We've got biological stochastic theories, which basically view aging as random, accumulated events over time, and then we have sociological theories. Think of the biological wear and tear theory, like a machine that's slowly rusting and wearing out just from years of continued use. Then there's the error theory. Picture a copying machine making smudged DNA copies over time. Our DNA transcription makes these tiny little errors that eventually compromise cell function. Now, on the sociological side, the continuity theory suggests aging is like maintaining your cruising speed and keeping your same habits through different life phases. On the flip side, the disengagement theory views aging more like pulling into the slow lane for a sort of mutual withdrawal from society. Understanding these really helps us anticipate how a patient might be declining physically, but also how they're adapting socially.
All right, Section 3, normal aging versus chronic illness. This is a massive one. A vital clinical skill for you in the field is being able to separate natural physiologic decline from pathologic disease.
So let's do a quick pop quiz based on a real-world scenario you are absolutely going to encounter out there. Meet Madam Essie Com. She's an 80-year-old female patient with a history of diabetes mellitus, and 2 years ago she had a stroke that left her with residual right-sided weakness. Now, as you walk into her living room to do your assessment, what specific characteristics of chronic illness are you expecting to find? Think about that for a second.
Well, let's compare the realities here. Normal aging involves things like decreased skin elasticity, slower reflexes, and decreased cardiac reserve. Those are completely natural. But Madam Essie Kumam's diabetes and stroke, those represent chronic illness. And chronic illness is characterized by the need for long-term management, non-reversible pathologic changes, and permanent impairments, like that residual right-sided weakness we talked about. You can't cure the damage from her stroke, right? But your nursing interventions absolutely must manage it to prevent any further decline.
Which brings us to Section 4, the changing body and mind. Let's map out exactly what kind of physiological changes you'll be assessing during those home visits.
Basically, the entire system slows down. Integumentary changes mean decreased elasticity and less subcutaneous fat. What does that mean for you? It means your patient gets colder a lot faster and they're at a super high risk for skin tears. Musculoskeletal changes bring stiff joints and decreased muscle mass, which obviously shoots their fall risk right up. Neurologically, we're looking at slower reflexes and a less efficient pain perception. This is a major clinical marker, guys, because a patient might not even feel a pressure ulcer developing. And cardiopulmonary-wise, expect less elastic blood vessels and a decreased cardiac reserve. Because their overall physiological reserve is lower, your nursing care has to feature a modified pace. You literally cannot rush a home assessment. You have to build in frequent rest periods for them.
Now, while mild short-term memory loss and slightly slower reaction times are totally normal parts of cognitive aging, there are some massive red flags you have to watch out for. We call them the 3Ds of abnormal cognitive aging: dementia, depression, and delirium. Delirium, for instance, is often an acute, completely reversible state. It could be caused by something as simple as an underlying infection like a UTI. And let me tell you, a UTI is a huge clinical predictive marker for severe decline and even mortality in home nursing settings if it's left unchecked. If you spot one of these 3Ds, immediate clinical intervention is non-negotiable.
Okay, our final stop. Section 5. Delivering holistic geriatric care. Let's take all these theories and observations and translate them into direct nursing action.
It's wild to look at how our understanding of geriatric care has evolved over the years. Back in the 1960s, the focus was mostly just on losses and adaptation. By the 70s, it broadened a bit to global and societal factors. But look at the 80s and 90s. This is exactly where modern home nursing lives today. The focus shifted heavily to the interrelationships between the physical and socioeconomic milieu. You aren't just treating a disease anymore, you are treating a human being existing within a very specific home environment with specific financial resources and complex family dynamics.
Because of that intense environmental focus, your assessments have to go way beyond just checking vitals. You've got to assess their psychosocial adjustments. How are they handling retirement, reduced income, or maybe a role reversal with their kids? Crucially, you have to play detective and actively screen for the 5 types of elder abuse: physical, sexual, psychological, emotional, and financial. You also need to keep a hawk's eye on hazards like polypharmacy and fall risks, and very carefully address their fragile fluid and electrolyte balance, especially since kidney function naturally declines as they age.
So here is your actionable step-by-step for holistic health promotion. Step 1. Conduct thorough annual physicals and cognitive checks so you can catch those 3Ds early. Step 2. Teach nutrition and exercise. And remember, contrary to that old wear and tear theory, safe exercise actually makes older adults more functional, not less. Step 3. Meticulously manage their medications and immunizations. And Step 4. Assist their families and the community setting. In home care, the family is practically your co-caregiver. Educating them is just as vital as treating the patient themselves. We have covered a lot of ground today. The science, the bodily changes, the massive difference between normal decline and chronic pathology, and the expansive, holistic role you now hold. I want to leave you with one final provocative question to chew on. As a home health nurse, are you prepared to look beyond chronological age to see and treat the whole person? Are you ready to look at their true functional reality, combat your own implicit biases, and treat the unique individual sitting right in front of you? I absolutely believe that you are. Thank you so much for joining me for this explainer, and good luck out there in the community.